Good afternoon, everyone. Myself, Dr. Himanshu. I am FNB fellow. I'm doing my FNB from Anup Institute of Orthopedics and Rehabilitation Center under the guidance of Dr. Ashish sir. He's my mentor and my guru. Today is my first talk on such a big platform, so I'm a little nervous also. So start with the main accused of this invention of cement because of prosthetic joint infections, which is the nightmare of any orthopedic surgeons. There is no gold standard for diagnosis, and there is no accepted standard definition is available. But some of diagnostic algorithm and treatment which was given by Pro Implant Foundation of Endo Clinic from Germany, which you can go through it. The option treatment for PGIR, the sir already has been, the things already had been told. The antibiotic suppressions, arthroscopic debridement, DARE procedure, and then it's come with the revision in 1 stage and 2 stage. In 1 stage, all we have to do in one sitting, the removal of old prosthesis, aggressive tissue debridement, and simultaneously placement of a new implant. In 2-stage surgery, there is a studies has been shown higher success rate, better infection control, and the most important thing is to improve it also improve osteointegrations, which leads to less chances of osteolysis and aseptic loosening of implant. That's why there is a more accuracy in implant placement. After thoroughly debridement, here is come the static versus dynamic cement spacers. It's divided into 2 types. We will discuss about types of antibiotics, doses of antibiotics. So basically, what is a cement spacer? It's a temporary biocompatible device inserted into a joint to maintain a joint space, which deliver antibiotics locally, stabilize the joint, prevent bone and tissue collapse, and facilitate future revision surgery. It's mainly divided into 2 parts. Static one, which is non-articulating, and dynamic, which is articulating. In static, we usually, if we are talking about TKR, we usually keep knee in a full extension or minimal flexion to prevent knee movement. It deliver antibiotics locally to infected area, which have a less systemic side effect. Maintain and sterilize the joint space and prevent bone and soft tissue collapse. You can see in this static spacer, this is how it made. We have a cement femoral rod which fixed with the K-wire or Steinman pin. We have a rod for tibial canal, and between them we have to put this spacer made by hand only. So basically, static spacers are temporarily molded arthrodesis block, and the cement is placed in between a joint to conform to shape of bone and bone ends and stabilize it. So advantages are basically it restrict knee movement between stages, distract and preserve the joint space, and provide the stability to the joint. The disadvantage of this, because of there is no movement at the joint are present, so patient may present with the contracture of muscles, soft tissues, ligaments, and also their fibrosis of joint. Here comes the dynamic spacer. Basically, it's a type of articulating spacers. It can be cement on cement, it can be metal on poly. So it's divided into 2 parts, molded one and pre-formed. The molded one is here, you can see. We have a pre-fixed available size are in the market, small, medium and large. There is only socket is there, which mostly made of silicone or some type of material. So we just have to put cements into this socket with the cement gun, and after mixing with the after settling time, we can see this beautiful picture of dynamic stabilizer. This is the pre-formed one, which is also available in market with various sizes. We don't have to do anything, just have to put into the joints. Here's some example we did in our institute. This is a dynamic type of spacer, molded one. And there is one term in dynamic spacer, this is a prostelate type of dynamic spacer, which basically type of functional spacer is made of antibiotics, cement, and has its own metal on poly. You can see in this diagram. And study has been shown with a good eradication rate and better patient mobility. So advantage are reduced bone loss. It basically reduces bone loss because the patient is mobile, maintain joint space, and there is a less chances of periarticular scarring. Disadvantage are there is a cement fracture will be there. There is a migration and dislocation of cement spacer, and adequate size availability is sometimes a big issue for this type of spacer. You can see in this example, the minimal available size was bigger for this patient. So patient developed skin blackening. So, but fortunately, the infection was not in the joint, was not on the joint. So we just thoroughly debrided it and put on wake dressing. This is on the left side. There is a static type of spacer. On the right, there is a dynamic type of spacer. Then the role is antibiotics. Types of antibiotics doses and combination of antibiotics. The property should be effective against both gram-positive as well as gram-negative. It should be stable, non-toxic, water-soluble, and minimize antibiotic resistance. Importance is we should avoid liquid type of antibiotics because of interference with the cements. The maximum ratio we can use is 10 to 15% weight by weight or 8 by 40 by weight by weight. Smaller molecule antibiotics should be avoided. We prefer hand mixing over vacuum because in the hand mixing there is increased chances of porosity in the cement, so much more and more antibiotics will deliver to the local environment. There's type of antibiotics like heat labile antibiotics, resistance. We usually prefer resistance type of antibiotics and variable one which have partially heat stability. Type of cements, there is a two type of variable available in the market. There is a Pelacos type of and simplex. Pelacos cements already have some pre-mixing of antibiotics within the cements. Then different type of Pelacos like gentamine loaded, which can be with gentamine with clindamycins, can be with gentamicin with vanco and tobramycin. Mostly used combination is genta with vanco, and alternate are also available. There is a table is for various type of antibiotics with different type of pathogens. The recommendation dose is 2 to 5 times from the prophylactic dose. And after this, you can go with second stage surgery on showing downtrending of inflammatory markers. And usually period should be in between the two stages is 6 to 12 weeks. It depends on surgeon and patient's condition. The conclusion is manage prosthetic joint infection. The cement spacer basically manage the prosthetic joint infections, deliver high local antibiotic concentration, and maintain joint space and promote tissue healings. Proper technique and patient selection is crucial. Here are some examples are there. This is a dynamic type of spacer, and we further the definitive surgery was a long stem. Here are some examples. This is a static type of spacer which eventually got dislocated, and after removing this spacer, you can see the quality of bone. It's almost okay. It's not very bad. And in this patient, we put a hinge joint. Hinge is prosthetic, and after 3 months of follow-up, 1 year of follow-up, and in 2 year of follow-up, patient presented with a fracture in same side of tibia. So we fix with the plate again. And this is the Pro Implant Foundation Endo Clinic, which gives good guidelines of related to prosthetic joint infection. You can go through it. And here is my some references. And thank you.
Thank you, Himanshu.